Good day, my dear postgraduate students. Welcome to Glide the Slide. In the last class, I had given you a history. We would see what the history is and the diagnosis. So, this was a slide that was put up, and the history was a slowly growing lesion of the jaw. It is too very direct because I have mentioned the site. But then there is a catch. I would like you people to diagnose, differentiate, and describe. So these are the three commitments for you people. I hope that we shall make the best out of it. Before I go into the diagnosis proper, always have a tendency to describe. Now, this is obviously a tumor. There is no normal tissue. And the tumor is composed of multiple islands. Some are small, some are large. In some areas, I find that they are anastomosic. Also, I could make out two components in each of them. There is a lining epithelium. In this magnification, that is a maximum I can say. There is a lining epithelium, and then there is a supporting stroma, which is somewhat squamoid in appearance. And supporting the entire tumor will be a loose fibrocollagenous framework. This much I can make out. The diagnosis is amyloblastoma. Given the history, the picture, it is classical. Malassez in 1885 gave the term as adamantinoma. Later on, this has been replaced by amyloblastoma. But the WHO has described it grossly as a solid, multicystic, or a unicystic variant. It can be intraosseous and gnathic, arising from the remnants of the enamel. And rarely, it can be from the odontogenic cyst. The clinical presentation. The age usually between the 4th and 5th decades. Unicystic can occur much earlier in the 2nd and 3rd decades. Extraosseous, on the contrary, or the peripheral variant can be in the 7th decade. I think it is easy for us to remember. 2, 3, 4, 5, 6 is missing and 7. It is locally aggressive. The common site is the mandible. And there are many microscopic variants. Thanks to this wonderful reference, I would like you people to kindly go back. The conventional tumor, it is usually asymptomatic. Intraosseous, in the sense it occurs within the bone and is an expansive lesion, slowly growing. There can be a presentation of malocclusion or a loose tooth, the third molar. Infection and pain can be the precipitating factors for the patient to come to the doctor. Occlusion is seen. And also there can be a hypercalcemia because it is intraosseous, therefore there can be a degeneration of the bone leading to a hypercalcemia. Similarly, a parathormone can also be raised. Both of these go hand in hand. Histologically, there are many variants: follicular, plexiform, basal, acanthomatous, and desmoplastic. There are many variants. Always, I would like you students to kindly know the classical picture and then the names of the variants. Even in your examination, if you do not mention the correct variant, you will be given the mark. On the contrary, if you are very perfect in the histological variant, that means somebody has given you the diagnosis. Look at this. There is a mandible and then there is a tumor over here. I could find a cystic lesion. What the WHO has said is something like this. It can be unicystic, it can be totally intraosseous, it can be associated with an unerupted tooth, it can be at the apex of the molar teeth or somewhere close to the epithelium. So these are the various sites. It can be again unicystic or multicystic. Sometimes it can be solid. The clinical picture is classically this. Thanks to pathology outlines for this wonderful picture of ameloblast. Look at this, there is a huge tumor. So no doubt about it. And then all the radiological and clinical findings will say that it is fixed to the bone. There is an asymmetry caused because of it, and too many things are there. Obviously, you need the help of multiple doctors in this case. This is what I had been saying. It can be at the apex of the tooth. It can be unicystic. It can be multicystic. And classically, they can give a history of a machine oil or a motor oil like material being precipitated from this. Machine oil or a motor oil. So the cystic spaces will be containing these. This is a structure of the enamel. So I'm finding the enamel over here. There are the odontoblast and there is a tooth. The ameloblast is a lining layer over here. If you look at it carefully, our tumor will be also having this kind of a picture. It is locally aggressive, commonly present in the mandible 80%, maxilla 20%. This we have already seen. The clinical presentation. The variants people should be having in mind. Follicular, plexiform, basal, acanthomatous, and desmoplastic. See, one thing is clear now is the parallel arrangement of the epithelium. This is called as a palisading arrangement. And there is a loose reticulum. My professor used to call it a stellate reticulum with, say, star-like cells. This can again be a pattern, the follicular pattern. It appears like multiple follicles of odontogenic epithelium. There is a fibrous stroma that is there supporting it. And inside, there is the stellate reticulum that I can see. The epithelium is consisting of parallel epithelium or palisading cells. And they will be showing a reverse polarity, which I had mentioned earlier in an ependymoma also. This is what is called as anastomosing. The islands of cells are being anastomosing so that you get what is called as a plexiform pattern, a network-like pattern. There is a delicate stroma that is again supporting it. In this case, the stellate reticulum that is supposed to be in the middle is almost inconspicuous. It can vary from tumor to tumor. After all, this kind of basaloid appearance, palisading, only a few are there. So you people should have your own short list of differential diagnosis. Thanks to web pathology for these wonderful pictures. They are all superb, dedicated work that we people should always appreciate and adore. It is not my own. So I am able to see the stellate reticulum, wherein I find that there are star-like cells. That is why it is called a stellate. And this is a tumor cell where there is a pseudostratification. There is also a parallel arrangement of the nuclei, which is called a palisading arrangement. And this particular diagram is much better. So there is a fibrous core over here, and this is the epithelium. And in fact, what happens is it is away from the base of it towards the apex, which is called as reverse polarization. Reverse polarization or polarity. It is common in the ependymoma also. Look at this one. So this is the Base of it, there is the basement membrane, the tumor cells, and then towards the apex, I find the piling up of the nuclei with a palisading arrangement. So I would like you people to again describe. There are some solidness, and then there are some with a delicate stellate stroma, multicystic spaces are also there. Therefore, it is a case of a amyloblastoma. Sometimes there can be areas of squamoid differentiation. A benign squamoid component can also be seen. Acanthomatous. Desmoplasia indicates a large amount of fibrous tissue. So, what is the differential diagnosis? You people will have to always think of. Think of the palisading arrangement that you people see, simulating the amyloblast. There can be areas of cystic degeneration and a myxoid or a stroma with a stellate reticulum. The other sides, extraosseous, it can be in the gingiva. Treatment is conservative surgery, cupping of the bone, surgery followed by radiotherapy. The diagnosis can be clinical, obviously, radiologic. Metastasis is quite rare, and the sites are the lung and the lymph. I hope things are very clear in an amyloblastoma. One thing I would like to mention is there is another tumor called craniopharyngioma. Craniopharyngioma in the pituitary. It has got an identical picture. If the patient is going to be given a history of a diplopia, etc., then you will have to think of a craniopharyngioma. There is a third lesion called adamantinoma of the tibia, which will be having identical histological picture. The relationship between these three, I shall be telling you in another class. We shall be gliding to the next slide. A 15-year-old boy with altered gait, and this is the lesion. See you in the next class. Thank you.